We're in time. So thank you everybody to wake up very early this morning for this lecture about posterior fossa anomalies. Can I have the, thank you so much. So in this lecture, I will try to be very practical. I will show you many cases, and I think the main issue is to have an anatomical approach of these posterior fossa anomalies. As you know, the analysis of the posterior fossa is performed on the axial plane. And the normality of the posterior fossa is assessed on three criteria. First, a normal cerebral anatomy, which means that you can identify two hemispheres and one vermis, a complete vermis, without any communication between the fourth ventricle and the cisterna magna. This is a morphological criteria. And there is two biometric criteria. The cerebellum biometry, the TCD, should be consistent with the gestational age, and the retrocerebral fluid space, which should be inferior to 10 millimeters. So, in the vast majority of cases, the pathological sonography findings, which lead to the diagnosis of posterior fossa anomalies, can be divided into increased fluid space of the posterior fossa, decreased biometry, and abnormal cerebral anatomy. And we published an algorithm on O6 about how to differentiate this kind of anomalies. It's a global approach. Each case can be discussed separately in a multidisciplinary approach. So when you have something wrong, you should go deeper in the algorithm and doing a careful analysis of some important anatomical structures. And you have to investigate the cerebellar tentorium, the vermis, and the brainstem. And in such a case, a strict mid-sagittal plane is mandatory. This is this plane at 20 weeks of gestation, the nasal bone, the corpus callosum, and you see here the vermis, which is more echogenic than the adjacent hemispheres. You can appreciate here this line, echogic line, which is primary fissure, divided the cranial vermis to the caudal vermis. At 28, you have the same kind of images. The vermis is more echogenic because the fissuration has increased, and you have a prepyramidal fissure here. If you need some more information, you can go to an MR. The MR is useful to have a good view of the tentorium, and the tentorium, the insertion of the tentorium is facing, is opposite to the nuchal muscle. And this, you cannot see this with ultrasound. For the brainstem, you see that the bulk of the bones is clearly visible because it's hyperintense compared to the hyperintensity of the peripheral spaces. So I will show you in a very practical situation how this algorithm can be of help. Situation 1, you see an increased field space of the posterior fossa with a free communication with the fourth ventricle. This is this kind of situation. And I will ask you, what is your first diagnosis? In that case, of course, you see the two hemispheres, and there is something missing in the center, which is a vermis. So your first diagnosis can be vermis agenesis, but it's not very frequent. It's very rare. So what is your other diagnosis? To improve, you have to do a sagittal view, and the answer can be, or is on the sagittal view. In that case, a very rare case, in fact, the tentorium look elevated, but to confirm, you should do an MR, and the posterior fossa looks enlarged, and there is a vermis here. And this situation is here. On tentorium elevation, enlargement of posterior fossa, you it may be a Dandy-Walker malformation. What's a Dandy-Walker malformation? There is a global winding of the posterior fosa because there is ascent of the cerebellar tentorium, insertion, and torticolor. There is cystic dilatation of the fourth ventricle with no communication with the subarctic spaces, and there is a vermis genesis. In fact, it's a rare entity. So you may have a Dandy-Walker malformation, but if you have more than 5 Dandy-Walker malformation a year, you may have a problem to really be sure that it's Dandy-Walker malformation. To assess the insertion of the tentorium, opposite to the nuchal muscle insertion, you may have to do an MR. In that case, you see that the tentorium is elevated, the torculus is here, and there is cystic dilatation here, and the vermis is dysgenetic. This is a comparison between ultrasound and MR. Regarding the prognosis of Dandy-Walker malformation, it has been postulated that fetuses with isolated Dandy-Walker malformation, characterized by small vermis with identification of 2 vermis and 3 lobes on MR, have a good clinical and intellectual outcome. However, we have underlined the inaccuracy of fetal MR for accurate anatomical analysis of the vermis in Dandy-Walker malformation, but MR is still mandatory for the detection of associated cerebral malformation. Now, you look at the tentorium in place. You should look at the cerebellar and biometry the anatomic biometry of the cerebellum, and it's normal. You may deal with a rotation of the vermis and a black spot cyst. You are in this situation, but according to the way you are scanning, the angle that you are used, you have a correction of the anomaly. Why? Because you are here in this situation, and the answer is one more time on the sagittal plane. There is a complete vermis with a normal height, but according to the way of your scan, you may scan like that and have the feeling that there is something missing, but if you can scan like that, there is a vermis. So this is the situation, and there is a good article by Ashley Robinson about this black spot cyst. It was published 10 years ago. And it's unlike Dandy-Walker malformation, it's a quite frequent anomaly. But it represents more a normal variant than a true pathological condition. However, sometimes it's difficult to differentiate Dandy-Walker malformation and black spot cyst. This is a false positive diagnosis of Dandy-Walker malformation. We have published a series in prenatal diagnosis. This is a false positive. We thought that it was a Dandy-Walker malformation here because we thought that the vermis was elevated, and it was elevated, but it was just a focal elevation due to the mass effect of the black spot cyst. So you may have a distal elevation of the tentorium, but in Dandy-Walker malformation, you have a global ascent of the tentorium. So in some cases, it's difficult, but the prognosis is completely different. In one case, you have a normal cerebellum, and in other case, you have a dysgenesis of the vermis. So speaking about continuum, it's a continuum for imaging, but for prognosis, there is no continuum at all. In one case, it's normal cerebellum, and in another case, it's dysgenesis of the vermis. So you may have this situation. You have a retrocerebellar fluid enlargement, free communication with the fourth ventricle, and the vermis is not normal. So you may deal with a vermis agenesis. In this kind of situation, there is something missing here, and here there is some body artifact here, but we have trouble to see the vermis here. And we plan to do an MR, but unfortunately, there is a premature delivery before fetal MR. So we do an MR after birth. We confirm there is no vermis here, but look at the midline. Here, the olfactory structure with the sulcus here, no sulcus here, noble here. And if you look at the baby, triangle here, this is a Charles syndrome. So, as you may know, vermin agenesis can be an associated anomalies in Charles syndrome, and look at this case for this kind of vermin agenesis at the olfactory structures. Situation 2, increased fluid filled space of the posterior fossa with a normal cerebral anatomy. It can be a black spot cyst, it can be an arachnoid cyst, a Megacisterna magna. In all cases, there is no need to differentiate Megacisterna magna or posterior fossa anomalies. We can have a very, I would say, asymmetric Megacisterna magna, but in all cases, you have a fluid filled space exceeding 10 millimeters with a normal TCD and a normal cerebral anatomy. But you should look for obstructive ventriculomegaly, and this ventriculomegaly can appear after birth. This is the old case, for sure. You have a ventriculomegaly and a dilatation of the third ventricle, and there is obstructive ventriculomegaly with destruction of septum pellucidum on the neonatal ultrasound, and on the sagittal view, you understand that there is a Megacisterna magna with mass effect on the tectum, which lead to the dilatation, the triventricular dilatation. In some case, some large posterior fossa arachnoid cysts can be associated with subependymal heterotopia. In this case, you see a large arachnoid cyst with an absent, focal absent of the tentorium here. But if you carefully, there is some nodularities here, which was heterotopia, subependymal heterotopia. But is there any interest of performing MR to diagnose this association? This prenatal diagnosis is really worthwhile, but you should know that there is a potential risk of epilepsy of the second decade. Decreased cerebral anatomy with a normal anatomy. That means the TCD is decreased, but you see 2 hemispheres and 1 vermis. You are, in this case, the decrease can be related to focal reduction of the TCD or global reduction. If it's focal, it involves 1 hemisphere. The question is, you are dealing with a classic event, primitive or secondary to CMV or phase syndrome, and you have to look towards the integrity of the vermis. You are in this kind of situation. The TCD is reduced for baby at 35 weeks of gestation, and you see there is some difference between this hemisphere and this one is smaller and more echogenic. When you look at the sagittal view, the vermis is complete, and you have confirmation that this hemisphere is reduced and hypointense compared to the normal one. But this baby has a normal vermis, and for prognosis, it's very important to know that the vermis is normal, because the vast majority of these patients have a normal cognitive outcome. This one, there is reduction of the vermis, but this one is hypoechoic compared to this one. And when you look at the sagittal view, in fact, there is reduction of the height of the vermis, and the fourth ventricle looks elevated compared to this one. The fourth ventricle is in the middle, and here it's displaced upward. It's not displaced. The upper part of the vermis is missing. You are in this situation, and this is MR. I prefer the ultrasound compared to the MR. Spatial resolution is better with ultrasound than MR, and because of that, parents decided to do a termination of pregnancy, because the involvement of the vermis is of concern for the postnatal outcome. Even in some cases, you can have a good outcome, and the pathological findings confirm that here there is clastic event on the upper part of the vermis. So extension of the classic phenomenon to vermis makes postnatal cognitive prognosis uncertain. You may have this situation, small vermis, small hemisphere here, but after birth, you have this hemangioma which appear in the first weeks of life. In such a case, you have phase syndrome. And we published a series of 26 cases of focal reduction of the cerebral hemisphere, and we have 4 cases of phase syndrome with posterior fosa anomalies, hemangioma, arterial disease, cardiac disease, and eye disease. And for the arterial disease, you may have some arteries missing, especially at the level of the cerebellum, which explains that there is underdevelopment of one hemisphere. Now, you have a global reduction of the vermis. You have to look at the brainstem, and for that, MR is not necessary, but is very useful. And you have the references for the biometry of the brainstem, and it can be normal, abnormal. You are dealing with pontocerebral hypoplasia or cerebellar hypoplasia. In all cases, the prognosis is on vast majority very uncertain. You can have aneuploidy, CMV infection, CDG syndrome, and primitive hypoplasia with some genetic disease, BART of oligoprenin 1 reelin. This patient was referred at 31 weeks due to isolated small TCD, but if you look here, the bulk of the pons is missing. And on karyotypes, it was 5p deletion Credusha syndrome. This is another case where there is major reduction of the TCD at 29 weeks with microcephaly. And you see that the Sylvian Fisher is very abnormal. There is echogenicity around the ventricle with calcification, and it was a CMV infection. I want to ask you something very important. Which sonographic follow-up is required in the case of medical history of primitive cerebellar or protocerebellar hypoplasia in a previous pregnancy? Do you change your follow-up for the next pregnancy? Why I ask you this question? This patient, third pregnancy, for the first one, there is a pontocerebellar hypoplasia. Second one, it was an infant full, and it was a normal baby. So you are scanning, this patient had 22 weeks, and the TCD is 22 millimeters. Okay, it's perfect, no recurrence. But at birth, you have this. You look at the hemispheres. There is a complete recurrence of the pathology. So it's essential to keep in mind the growth of the fetal cerebellum during pregnancy, which is linear till 24 weeks, but has asymptomatic growth after 6 months related to intense neuroblast proliferation leading to the granular layer of the adult cerebral cortex. And you have some phenomenon, pathological condition, in which this growth is affected. That means that you have a normal TCD when you do your ultrasound on the, at 22 weeks, but it will be affected on the 6 months. That means that the rules that TCD is equal to the number of weeks of gestation is true till 24 weeks, but it's not true after 6 months due to this particular cellular proliferation. That means at 21, you are 21, but 26 is 28, 29, 28 is 32, and 32, the mean is 39. So it's very important to keep this in mind, because in that case, at 22, it was 22, but the gynae scan the patient at 27 and say it's okay, it was 27, but it was not okay, it was the 10th percentile, and when you scan at 33, the TCD was 30, and you expected a TCD of 42, and it was a complex recurrence. So you have to keep in mind this that if you have hypoplasia, the follow-up for the next pregnancy should integrate a scan at 28 weeks just to be sure that the TCD is 32 at 28 weeks of pregnancy. Now, abnormal anatomy associated often with decreased cerebellar or vermis biometry. You are, in this case, dealing with abnormal echogenicity of the vermis. The vermis should look more echogenic than it looks in that case, because in that case, the vermis, if it's a vermis, has the same echogenicity than the adjacent hemisphere. And the height of the vermis is, in fact, not increased compared to a normal one. If you look carefully, in fact, on the axial view, but I think it's better visualized on this corner view. You see that the foliation comes from one side to the other. It's like a stripe on with the shirt, and there is no vermis in the middle. So there is a sort of block, and this block is a romboencéphalo-synapsis. And in that case, you have a small round fourth ventricle, and romboencéphalo-synapsis can be associated with ventriculomegaly and septal agenesis. It was said it was septal agenesis, but it's not a septal agenesis. It's an obstructive ventriculomegaly, because in such a case, you have a romboencéphalo-synapsis with also atresia of the aqueduct and obstructive ventriculomegaly. So in some case, we can have romboencéphalo-synapsis, atresia of the aqueduct, and in some case, we have diencephalosynapsis. It's a sort of continuum with trouble of differentiation of the diencephalon, mesencephalon, and romboencéphalon. So you may have a simple romboencéphalosynapsis without ventriculomegaly, but you can have romboencéphalosynapsis with atresia and ventriculomegaly due to atresia of the aqueduct. Now, very simple case, hypoplastic posterior fosa with a reduced TCD, abnormal cerebellum anatomy, the banana shape here. You see that the Megacisterna, the cistern magna, is not visible. There is the lemon side, so very simple case. Look at the spine. In that case, this is a lumbar, sacral, myelo-meningocele, and there is no difficulty at all. You just have to know that when you don't have this cistern magna, you have the banana shape. Look at the spine. This case was referred for abnormal hypoplastic vermis on ultrasound. You see, it's very difficult, small. Is it the primary fissure? Difficult to say. Look at this image, and this is, in fact, elongation of the cerebellar peduncle here, and this molar tooth sign. This is a Schubert syndrome or related disorders. What is this molar tooth sign? Here are normal superior cerebral peduncles, and you see if, in this case, there are thickening of the peduncles and, in fact, horizontalization of the peduncles, and it looks like a molar tooth. And this is very typical of Schubert syndrome and related disorders. Schubert syndromes can also be diagnosed using ultrasound. It was published the first time by Denis Pougache, and in that case, you see that there is thickening and elongation of the peduncles. But what is important? This is maybe difficult to identify, but look at the shape of the fourth ventricle. And it's easier to look only at the shape on a routine examination. And we published this series of 7 cases to say that if you have to look at something, look at the shape of the fourth ventricle. In normal cases, the AP diameter is smaller compared to the transverse diameter. But because of the elongation of the peduncles in Schubert syndrome, the transverse diameter is smaller than the AP diameter. So this is in routine. You may not see that it's Joubert syndrome, but you have to notice that the fourth ventricle, the shape of the fourth ventricle has changed. Now, we saw romboencéphalo type 2, agenesis and dygenesis, and you have a list of Joubert syndrome, Charles syndrome, and other anomalies of the fissuration and foliation. So I think before the last situation, this algorithm is simple, and using this, it's a very anatomical approach. We use the same term with the pathologist, and you see that I don't speak about Dandy-Walker variants, and I think this terminology should be deleted of our vocabulary. So it's simple. It's maybe too simple, but it can be of help in practice. Now let's focus on last situation, not included in the algorithm, abnormal focal cerebellar echogenicity. Case 1, the context is suggestive of a severe vascular IOGR with patients with hypertension and chronic renal failure, and you have an echogenicity here, abnormal echogenicity on one hemisphere. Such echogenicity is very suggestive of a classic event, ischemo-hemorrhagic, and when you perform MR, you say that there is here hypointense lesion suggestive of hemorrhage with edema here, and this will be confirmed if you do a follow-up, but because with the follow-up, you have a rapid liquefaction, a necrosis of the hemisphere, and there is amputation here, which appear very quickly in two weeks, and you have echogenicity of the meninges here. So, very simple, you have a focal echogenicity, you wait for 2 weeks, and the image will change and with the amputation because of necrosis. Case 2, cerebellar echogenicity in another context. Focal echogenicity detected on a routine scan at 22 weeks with a normal MR at 26 weeks. And this patient was referred for that. You see, here there is a large echogenic area without any anatomical distortion of the cerebellum. Nothing very interesting with Doppler, and an MR was performed and complete normal. What is the diagnosis? MR is superior to ultrasound for sure, so if there is nothing on MR, there is nothing for sure. But look at the ultrasound. I prefer to look at the ultrasound. Here there is echogenicity. It cannot be a variant. You may change. It's not a problem of foliation. We published that with abnormal foliation, you may have increased echogenicity on some part of the hemisphere, but here it's on all plane. It's like this, and there was termination of pregnancy because the parents was of concern regarding the postnatal prognosis. And this is the pathology. It's a normal cerebellum with very large capillary. And it's a capillary telangiectasia of the cerebellum. This is, in fact, an incidental finding. When you have a capillary malformation like this, you have a complete normal life. In some very rare case, you can have a small hemorrhage, but it's an incidental finding. And there is this paradigm of the optimal combination of ultrasound and MR for this diagnosis, stable echogenicity of the cerebellum without any distortion of the cerebral anatomy, plus paradoxal normal T1 and T2 weighted images. This is capillary telangiectasia. And we have a chance, we published this in 2003, but 6 months after, we saw this case. This case was referred for a discrete echogenicity on one hemisphere at 32. At 34, it was stable here. We did an MR, nothing on MR, so we say it's a capillary telangiectasia. So we were a little bit afraid not to be right. I did the MR after birth, nothing. You do injection, and when you inject here, you have a capillary telangiectasia. Because to see the capillary telangiectasia, you have to inject the patient. And because there is no injection, there is a pregnancy, you have this paradigm that you have an abnormal ultrasound with normal T2 and T1 weighted images. There is no flow because capillary telangiectasia, and there is no flow. And in fact, if you do T2 star, you may have hyperintensity. So as a conclusion, one quiz is still abnormal echogenesis of the posterior fossa. You see, you have a complete vermis here, but you have a round wheel here, echogenic. Is it a large clot in the posterior fossa? Maybe, but it was very stable over time. And we did an MR. Look at that. This is here. And you see that the signal of this mass is very similar to the cerebral tissue. And it was an intracranial, extracerebellar, neuroglial heterotopia. It was a picture of the month 2004. And thank you for your attention. We have time to 1 or 2 questions if needed. You have my email, so if you have some questions. Yes? Please.
What about the fastigium in Joubert?
What?
About the fastigium in Joubert syndrome?
The fastigium is Joubert syndrome. Can you be more precise?
May I ask you a question?
Yes?
Yes. In one of your images of a capillary telangiectasia, you showed very well a small but very definite vessel. It was venous vessel. Why do you call this capillary telangiectasia and not developmental venous anomaly?
In fact, you can have both exist, but this is capillary telangiectasia and not DVA. DVA is developmental venous anomalies, but in that case, you have true capillary in the malformation. You can have association of DVA and capillary telangiectasia, but with DVA, you don't have this kind of images.
In neuropathology, we have definitions for such entities. Capillary telangiectasia is very small capillary lesion, usually in brainstem.
It's in brainstem, most of the time brainstem.
Yes, but developmental venous anomaly is a very common one, and what is interesting, it has a collector vein, usually quite big one, which collects the venous flow outside, and you show it very well in your images. You can put it.
Yes, but for sure,
previous one.
You don't in DVA. In DVA, it's you don't have this capillary.
Yes, but you cannot find this a collector vein in the histological images. You can see it very well in Doppler imaging. Take one back.
Yes, but this is
yes, no,
this is
yes, exactly. This is very good sign of
for sure
collecting vein.
No.
We have a series. Go to hub.
I am in charge of the consultation for angioma in my hospital, so we may discuss this. But for sure, we don't have to mix DVA and capillary malformation, and on the pathologic specimen, it was large capillary and not a DVA. And DVA can be associated also with...
discuss it later.
Okay, thank you.
I mean, I read somewhere that in Joubert, in the mid-sagittal view, the fastigium and the fourth ventricle.
Oh, so. It's Rabi. Okay.
Bonjour.
Oh,
Bonjour.
Because of the light. Okay.
I said that in the mid-sagittal view, it's said that the fastigium and the fourth ventricle may be also very suspicious in Joubert syndrome.
You may be right because you know everything about Joubert syndrome.
No, but I mean, because you showed the picture and you were showing us one case with the small superior vermis.
Yeah.
How important is for you also the fastigium in these things?
I think that the most of two sign is so important that you may have some modification of the fastigium and you have also degenesis of the vermis. But to diagnose this entity, you have to focus on the elongation of the peduncles and of the modification of the shape of the fourth ventricle. And in routine, for experts to look at the fastigium, it can be useful, but for sure, you can have modification of fastigium without modification of the fourth ventricle. In that case, it's not Joubert syndrome.
Okay, thank you.
Thank you very much. Have a good day.